myelodysplastic syndrome, leukemia, and paroxysmal nocturnal hemoglobinuria. Myelodysplastic syndrome can present with, if you do a bone marrow on those patients, most patients will be either hypercellular or normocellular in their bone marrow. About 10% of patients are hypocellular. They do the bone marrow, it's hypocellular, and they send it off for cytogenetic analysis, and there's a cytogenetic abnormality, then the diagnosis would be myelodysplastic syndrome. Aplastic anemia is not associated with any cytogenetic abnormalities. There are some cases of myelodysplastic syndrome that don't have cytogenetic abnormalities, and then you're basically got to pick what you want to do based on the presentation and the age group of the patient, things like that. Pure red blood cell aplasia. It's the selective absence of erythroid precursors often associated with thymoma, drugs, CLL, and collagen vascular disease. Parvovirus B19 is probably the most common cause, and in fact most cases that of parvovirus that cause anemia we probably never diagnose because it's self-limited and just improves on its own in a couple of weeks. Recently, erythropoietin therapy has been implicated as a cause of pure red blood cell aplasia, and these are case report and a series of cases in which patients who got erythropoietin developed anti-erythropoietin antibodies and ended up developing a pure red blood cell aplasia. This was really seen in the products that are used in Europe rather than Epogen and Procrit, which are used here in the U.S., but again, this is being monitored. Like I said, it's transient and self-limited in most people, and so we probably never diagnose it, but a severe aplastic crisis can develop in patients with chronic hemolytic disease like sickle cell anemia. When the aplasia is severe, you treat with IVIG and with supportive care and transfusion. Anemia of renal failure. Now, this is primarily due to, again, the diminished erythropoietin production. Okay. Anemia is present when the creatinine clearance falls below 45 milliliters per minute. These patients you do treat with erythropoietin, and what the treatment with erythropoietin has shown in patients with renal insufficiency, not with renal failure on dialysis, but just renal insufficiency, is that it may slow the progression of renal failure. And in patients who are on dialysis, it certainly increases quality of life, and it probably increases lifespan as well, and there are a few studies that suggest that. The one thing that you need to make sure in patients who are getting erythropoietin is that their iron stores are replete. Because what's going to happen when you start giving the erythropoietin in an anemic patient, they're going to use up all that iron to make blood cells, and you can actually make the patient iron deficient and cause them iron deficiency anemia by giving them the erythropoietin. So make sure that the iron stores are replete, and a lot of people will say you should treat with iron if the ferritin is even less than 100. Look out for coexisting causes of anemia, including iron deficiency, folate deficiency, and aluminum toxicity. So macrocytic anemia, we really break this down into non-megaloblastic and megaloblastic anemia, with vitamin B12 and folate really being the major causes of this. And the MCV can be very, very high. Only situations where you're going to see such a high MCV. Hypersegmented neutrophils and macrovallocytes on the peripheral smear are virtually pathognomonic. A hypersegmented neutrophil, if there's more than 5 lobes, is very, very sensitive for megaloblastic anemia. Now, remember that you can see a pancytopenia and an elevated LDH and indirect bilirubin in these patients because there is some hemolysis within the bone marrow, but it's not in the periphery, so you do not see the reticulocytosis and that you would see with a hemolytic process. So vitamin B12 deficiency. Now, most causes now we think are caused by what we call food cobalamin malabsorption, or the inability of the stomach to cleave vitamin B12 from the food that you ingest. And this is really more seen in the elderly patients. The other major cause is pernicious anemia. Other causes include gastrectomy, ileal resection, and vegan diets and vegetarian diets. You can actually have a low B12 level with no abnormalities, and you can have a normal B12 level with actual deficiency. So this goes to saying, well, the B12 level is not a great marker for B12 deficiency, but it used to be one of the best things we have. Now people are saying, well, if we look at the metabolites of vitamin B12, maybe this will help us some more. And so we have the methylmalonic acid and homocysteine levels, which would be elevated in a patient with vitamin B12 deficiency. Methylmalonic acid is very specific for distinguishing between folate deficiency and vitamin B12 deficiency if the patient has normal renal function. However, there is a big controversy over the role of methylmalonic acid. There are some people who would suggest that you don't even need to check a vitamin B12 level. If you're looking for B12 deficiency, check a methylmalonic acid level, and if it's elevated, the patient's B12 deficient and you should treat them. Well, what's the problem with that? Well, we don't have any studies saying that if you treat patients with elevated methylmalonic acid levels, you actually get improvement in their any sort of symptoms. So there have been a couple of studies in elderly patients who've had low normal B12 levels, elevated methylmalonic acid levels, and they treat them with vitamin B12, and they found absolutely no improvement in cognitive function or in abilities to do ADLs or anything like that.
I'll write it over here. It's hard to see, sorry. Pi is defined as 1 over twice F pi times this condensate dotted into the gauge field. That's all that's on. It's a common notation, yes. Well, it is. I mean, we did that. If you look at what the pions do, in some sense, that's what we did whenever it was Monday of this week, I think, or Tuesday, I forget. But so it is. But the point is to generate this without worrying about those triangles. See, the quarks have all disappeared in this formulation. The mesons are all either pseudo-scalar fields or pseudo-vector fields or something like that. So the idea is, can you describe those interactions without going back down to the quark level? And the answer is, yeah, that term doesn't. That's so you could. That's what people did. And so that makes sense. Basically, yes, that's right. At the condensate level, that's correct. The idea is the quark terms just get wiped out entirely. The mesons have no idea they're made of quarks. They behave according to that effective action with that other term. And this works very well, actually, to describe low-energy meson physics. In fact, it works better, I think, than people thought it ought to when they constructed it. So the idea of that was to show you, it was to follow up on what that X-gamma stuff does. It's used in generating, it can be used in generating effective actions, and partly, I guess, still is used if you're a person who believes that there is some structure to quarks or leptons or what have you, then similar ideas would be used, that an electron is a condensate of, I don't know what, preons or retons or something. Those ideas were used there as well. To my knowledge, there is no positive evidence to support these kinds of substructure models. People don't work on them anymore, or hardly anybody works on them anymore for that reason. And the favored substructure model, as we call that, would be something like string at this point. Yeah. Pardon me? I don't know why you would maybe gray man.